Now, my talk today has been put on defining laboratory testing for COVID-19 and pre-screening, screening, and confirmation. So I'll just go right away into the thing. And thanks, Mindray, for having this online seminar. So this is the place where I work. For those of you who don't know, this is BL Kapoor Hospital in Delhi. And we had been designated as a COVID hospital recently, a part of our hospital, but there's been a change in the thought process now. And the administration, the Delhi government has now decided that instead of having a COVID hospital, a part of the hospital as a COVID hospital, you will actually have the entire hospital designated as a COVID one rather than only the part of it. So therefore, we were a part of COVID, and now we are not really a part of the COVID, but yet as a group, we still continue to be a part of the COVID process. All right. So at the outset, I would like to put in a disclaimer that most of the views which are here are only mine, and they have primarily based on the literature which is available on the net. And I'm sure a lot of you would have probably read it also, and I do not have any significant conflicts of interest. Now, the picture which I'm showing in front of you is something which probably will never happen again in our lifetime, I guess. You know, you would sneeze and people would say, God bless you. And that is no longer the reality anymore. What will happen probably now is everybody who looks at you now sneezing, the only thing and the only picture which will come to anybody and everybody's mind is this picture. Mind you, I don't know how many of you realize that this is the most looked at picture, you know, on the internet, at least for the last 2 months now. And it's interesting how this one small little particle has changed our lives. And it has changed our lives to the extent that even the people who are at the helm and who are really trying to look at things and getting things done, they have to actually use helmets like these and scare the people away back into their homes. But that's really what we have in life now, and this is what we have to keep, you know, in our minds. And healthcare people, the people at the front line today are the healthcare professionals, which includes your doctors, your nurses, your GDA staff and other staff, which are actually really at the front line dealing with the patients and trying to, you know, help the patients out in this hour of crisis. And most importantly, when these people are actually really sitting at the forefront and trying to see, the biggest problem which most of us will face will be the overlap of symptomatology between various diseases. That's your coronavirus, the common flu, the cold, etc., which always has an overlapping symptomatology. And therefore, for anyone to really come to a final conclusion, you will have to depend upon nobody else but the laboratory. And that's where the lab's role starts coming into a big way. Obviously, in a laboratory, the first step obviously would be to ensure that we have been sitting across onto the channel in such a way that we are able to decide which test would be appropriate and which would be the best modality to do. We would need to get our logistics in place, ensure that everything is available. We must validate our testing appropriately. And then, of course, the Eureka, the test, which is currently the big test available, that's your RTPCR test. Everybody wants to do that. And eventually, it is this test, the information from this test, which helps us to guide our clinical colleagues as to whether the person is having COVID or not having COVID. Now, if we define the laboratory testing, the wish list is at 3 levels. One, the people and the patients in general, they want a rapid, a reliable, and a cost-effective test. And we have heard recently, the Honorable Supreme Court wants the test free, and we have already started doing it free across the country. What does the government want? They want a rapid, reliable, and a cost-effective test as well. And of course, from our end, of course, we will not talk about the free part of it, but for sure, we also want a rapid, reliable, and a cost-effective test. So obviously, when we're looking at a test, we're looking at a test which is people or patient-centric. So if we look at the laboratory perspective, it's our ethical obligation to provide an accurate, precise, and a precise test which is available within the shortest possible turnaround time. And as I told you, cost-effectively. And more importantly, at the back end, we need to make sure that the environment which is provided for our staff to work is safe. And at the same time, if we could do some research and innovation. Okay, so when we set up a test, what is always playing on our minds? Most of us are laboratory professionals. The first thing that comes to our mind is that we want a test which is highly specific and which is highly sensitive at the same time. Now, most of us will understand that this is not the reality. In reality, you do not have a 100% true positive and a 100% true negative scenario. In other words, you do not have a zero false positivity and a zero false negativity. So in such a scenario, setting up of a test is always a challenge in any laboratory. What if we could get a test like malaria antigen and just put in a drop of blood onto that and see the card and decide, okay, fine, great, we've gotten a positive test and this is corona, and we've got a negative test and this is not corona. Now, if this is how the wishes would be, life would have been much simpler. But how do we design a test? The design comes directly from the structure of the coronavirus. And if you see the coronavirus structure here, you are able to see these envelope. The envelope has these proteins, and within that protein tissue structure, you have the single-stranded RNA. So what all can you target? You can target the proteins, identify an antigen from there, or identify and quantify the antibody in somebody's serum and see whether you're having that antibody against these antigens. Or more specifically, you can go to the single-stranded RNA itself and start looking for a specific sequence on the RNA and get the information as to whether you're dealing with this virus. These are various other nuclear proteins which are shared commonly between coronaviruses. I will not get into details of them. The most important point comes in this particular diagram which you're seeing over here. What's obvious is that the SARS coronavirus is actually a part of a bigger group, which is the beta coronaviruses. And a lot of these proteins are shared by a lot of them. So therefore, actually, if you really go ahead and do only the antigen testing with respect to these kind of proteins, you may not be really doing justice, and you may actually not be identifying the particular virus, which is your COVID-19 virus. So what do? We therefore look at the possibility of the trimeric spike protein, which is out here. This particular protein helps you to identify some of them. And of course, a lot of the testing is dependent upon the viral RNA. And I'm sure a lot of you would have read about it already in the literature. Now, if we look at the disease per se, what are we able to see with respect to the disease part of it? The disease shows an early infectious stage where the viruses are replicating. All this is happening within the pulmonary system of the patient, and eventually the body tries to fight out the infection, which is your host inflammatory response phase. And it is at those phases that the inflammatory cytokines start coming up and you have the DIC-like picture. A lot of it was discussed by Dr. Nair, and therefore I'll not get into details of that. However, the moment we try to target the PCR part of it, this picture needs to be kept in mind. And in this picture, which is obvious, the RNA starts coming from day 0, and you are able to actually see and this is usually within the symptomatology period, and you're able to pick it up for a pretty long time, till almost 15 days. Now, when you look at the RNA, it's a single-stranded RNA, which is having a 30 kilobytes length. It has got various proportions, which are actually, using their proteinaceous differentiation eventually based on what we have just shown in this picture as well. Now, if you look at the RNA part of it, there are 3 important genes which people look at. One is the RDRP gene, the other one is the E gene and the N gene. And for all of them, fortunately, we have the oligonucleotide primers which are available. They have already been sequenced, and that's why the kits are easily available for us. What one needs to remember, though, is that these genes are not otherwise genes which are not shared between other coronaviruses. So it's about which gene will you take for identifying the virus. So let's look at this particular PCR assay, the RTPCR assay, which seems to be the most important assay currently, and everybody wants to use it, was originally proposed by Chartier from the Berlin University Institute of Virology. And this was the assay which was actually endorsed by WHO. And at the same time, it was also being concomitantly developed by the CDC as well. There was a concept of screening and confirmatory testing. I know a lot of people would remember that the screening and confirmation part of it is also given in the advisory from the ICMR. And if you look at both of them, this is how the entire thing pans out. So you have an E-gene assay, which is used as a screening tool. And this E-gene assay is primarily used as a screening because it is a gene which is shared by a lot of coronaviruses. On the other hand, you have the RNA-dependent polymerase gene assay, which is a confirmatory assay. And this is what the WHO strategy was, that you start with an E-gene assay. If that turns out to be positive, you do an RNA polymerase gene-based assay for confirmatory testing. Concomitantly, you can add another confirmatory assay using the N-gene assay. Now, this part of it has actually changed a lot with CDC now, where they have directly gone into the confirmation mode, and they have gone directly to the COVID-19. So these are the various targets which you can potentially look at. And I would like your attention on these genes vis-a-vis the number of copies, where you have to understand the limit of blank is to the level of these copies. And this is why it's the important point here is that having it below this level might always become a major challenge. So if we look at the coronavirus, in terms of the assays, when you're trying to see with respect to the real-time PCR assay, with respect to the various sources of sample, what you will observe is that the nasopharyngeal swab samples and the sputum samples correlate very, very well. And eventually, whether you look at the severe and the non-severe patients, the signals are exactly the same, and you're able to actually pick them out very, very clearly. More importantly, the picture G, if you see, is very clearly showing that you have a better outcome from the sputum. So obviously, the samples which are coming from the chest are far superior. Let's look at what other tests can potentially be done. You can look at the antibody against the COVID-19. And this is the premise for this is that you have the antibodies which are going to be produced after you're getting infected with the virus. And this usually happens on day 7. And it continues for about a few more days. So you will have the IgM and the IgG. And this part of it is already known to a lot of us in other viral illnesses as well. Now, what are the ways by which you can identify these antibodies? There are two prominent ways by which you can identify them. One is your ELISA-based assays, and the other assays which you can do is immunochromatography. And I'm not really going to get into details of this because I'm aware that most of us have been doing this for other diseases, and these two techniques can potentially be used. Let me just try and show you what has come out with some of the studies which have done this. And this picture is actually showing you how the immunochromatographic technique will be giving you the bands, which we are already familiar with when we do malaria antigen testing. This is an actual case scenario here where you're seeing one of the publications which was there, which showed us how different scenarios were there. In the first one, you are able to see both IgG and IgM. In the second one, you're not able to see only a very faint IgM is there. In the third one, there is no IgG, no IgM. Fourth one, you have a very faint IgG, and likewise in the rest of them as well. What is important to know is to see this particular picture in front of you, which is very obviously telling you the titer of these antibodies and how these titers differ in different individuals. So if you look at the titer is pretty high when you're seeing here the strong ones, and the ones which are weak are also there. So you have a responder which is producing a much higher level of antibody, and the ones which are producing relatively lower levels of antibody. And if you look at the levels of antibodies within and the severity, you will observe that the patients who have lower levels of antibody are less severe than the patients who have a higher level of antibody, and that's what has been demonstrated in this. This is also eventually correlating with the viremia. So the viral percentage of viral clearance, if you look at it, the ones which have non-severe patients where the antibody levels were lower, their viral clearance incidentally was better compared to the ones which had a severe disease and their viral clearance was more difficult. And again, if you look at the various days from the time of illness when the patients had the IgGs, the IgMs, and the RNA positivity, what's pretty obvious is that you start having these antibody only on day 7 of the illness. And as you progress further, the RNA starts getting dwindling on, whereas the antibodies start becoming more prominent. Okay, so what are we left with? We're left with the antigen tests. So antigen tests have a sensitivity which is as low as 34%, to some of them to add as high as 80%. But currently the WHO does not recognize the use of antigen testing for diagnosis of patients with COVID, although they're very clearly saying that it's highly encouraged to keep looking for a possibility of using antigen-based testing. Now, you know that I'm a hematology person and I have an itch of hematology. So I would really want to know how does hematology help us in getting the assay further? So if you look at this particular picture, I am going to talk a little bit about morphology as well as about the flow cytometry. This particular picture very clearly shows you that what I'm able to show you here is that you have a healthy donor and you have these patients, and in all of them what you're able to see is the presence of these monocytes. And what is very striking in all of them is that if you look at flow cytometry, the monocytes which you're seeing in this are the monocytes which have a very high forward scatter. And these monocytes are actually different from the usual monocytes which you find. So that's what has been seen in flow cytometry. And the p-value is very obviously different with a high forward scatter monocytes. And then this is a typical image where you are seeing a flow cytometric image of high forward scatter flow cytometry, and you are able to identify these monocytes very distinctly separately. In fact, some of it was already shown by Dr. Sukesh as well. On the contrary, if you are looking at the forward images which you are seeing on the flow cytometry now, what you are able to see that these high forward scatter images are also available, and they can be taken care of along with that. So therefore, for us to actually really do flow cytometry will really help us in the long run. So what we are doing in this next image, what I'm showing you is the markers of expression which are done on flow cytometry. And these are the ones which are, just give me a second. Sorry. So what we are seeing here is the presence of the macrophage markers which are present on these, and they obviously get activated during this particular illness, and we can pick them up on flow cytometry as well. These are the other macrophage markers, and other possible points which one needs to keep in mind is you can also look at the presence of various T lymphocytes and various other lymphoid cells as to how they express. The most important ones being the presence of CD27 and CD38 high expression in these cells, as well as presence of HLA-DR and expression of CD14 and 16 on the monocytes. There is also expression of granzyme A, B, K, and M, and perforin on all these cells, and as you can observe in this particular flow cytometric scatter plot. Now let's look at the counts which are there, and if you see that these pictures are from patients, who are from the cases of COVID pneumonia, non-serious COVID pneumonia, and what you are observing in all of them is that there is distinct lymphocytopenia, something which Dr. Sukesh already showed us. There is definite count low as far as CD3 and 4 positive cells are concerned, CD8 positive cells are concerned. There is hardly any difference in the ratio though, which needs to be understood very, very clearly. So the ratio does not get affected. So it's not like typical HIV-like illness where you have an alteration in CD4 to CD8 ratio. Again, when you're looking at the mild and the severe forms will obviously have a much worser, proportion of reduction in these cell counts. And important point is that the ratio still does not really get affected to that extent. And as the patients recover, what you're able to observe that the recovery is also giving you recovery in the counts, and they are all coming back in that particular patient. So this is an ROC curve which is showing various cell counts vis-a-vis the sensitivity and specificity of the illness. And it's very obvious what you can see from here that the regression analysis shows that all of the counts with respect to cytopenias are able to give you some information. Same thing has also been seen in some other publications. Again, I'll not get into details of this, but this is again something seen both in ICU as well as in non-ICU patients with suffering from COVID per se. Now, what are the other tests which can potentially be looked at with respect to the laboratory testing? If you see that you will also be looking at the D-dimers, the neutrophil counts, the creatinines, and the urea, and it is not a rocket science to know that as you are having the survival, if you are surviving, you will have better counts vis-a-vis the ones which are not surviving. So if you see the urea and the creatinine, they're getting deteriorated in patients, who are having this disease, which is very, very significant. And the ones who are recovering are obviously coming back to the baseline. Similarly, if you look at the temporal changes of the laboratory markers in D-dimers, in lymphocyte counts, in IL-6, there was a question as well. In all those cases who are actually getting into a macrophage activation syndrome and having a very severe DIC, it's pretty obvious that all these markers are actually becoming very severe and giving a tough time to the patient as well. So what should be the testing algorithm? How should we go about testing a person if somebody is being suspected of COVID or even to allay somebody's fears? We would like to have a reliable procedure which should be pretty simple. You should have a specificity which should be pretty high, and it should be easy to use. Now, when we say all this, it is possible in a usual circumstance. The current circumstances that we are placed in, we are placed in a time of rationing. And therefore, that's where it becomes extremely difficult for us to decide who to test and who not to test. So if we look at the current recommendations in the country, the Indian Council of Medical Research virtually changes their versions almost alternate day basis. And the latest version, which I have been able to lay my hands on, is this one, which says the strategy of the version 4 dated 9th of April is the following. Number one, all symptomatic individuals who have undertaken international travel in the last 14 days, all symptomatic contacts of laboratory confirmed cases, all symptomatic care workers, all patients with severe acute respiratory illness, which includes fever and cough and or shortness of breath, asymptomatic direct and high risk contacts of confirmed case should be tested once between day 5 and day 14 coming in his/her contact. In addition to that, they have also given us recommendations with respect to the hotspot or cluster testing, where they've said that all symptomatic patients who have this upper respiratory like illness, they should be tested within 7 days of illness with RTPCR, and after 7 days of illness, first the antibody test, and if it is negative, you can do an RTPCR. As far as the cluster testing is concerned, there is a very interesting the chart which is given with respect to testing, where they're talking about rapid antibody testing and looking at it whether it's positive or negative. And then if there is a possibility of RT-PCR, confirming by RT-PCR. However, if there is no RT-PCR, you will consider it as positive case and then quarantine accordingly. Now, if I look at the testing algorithm per se, for me, as on date, I would prefer the test to be done only in symptomatic patients. And I would prefer a combination of RT-PCR and antibody testing, because that would let me know whether the patient is having and what will be his immune status at some point of time. If I cannot do that, which obviously I cannot, the easiest and the best thing to look at is at least follow what we are following down here. That is, within first 7 days of illness, look at the RT-PCR. And if it's after 7 days of illness, do an antibody test. If negative, then do an RT-PCR. Perhaps that will help us to channelize and have our testing algorithms taken care of. Just to give you a view of how to interpret these tests, if you look at the RT-PCR, IgM and IgG in totality, if you have RT-PCR positivity, the patient may be in window of infection and may be asymptomatic also. If you have RT-PCR positivity with positivity for IgM, this is an early stage of infection. If you have all the three positive, that means the patient is surely infected and has an active phase of infection. If you have RT-PCR positivity and IgG positivity with no IgM, that means he's perhaps in the late stage of infection. If you have only IgM positivity, then it may be an early stage of infection and RT-PCR may be false negative. And this is what needs to be kept in mind. There are about 30% cases where the RT-PCR may be clearly negative and it may be falsely so. If you have only IgG positivity and RT-PCR is clearly negative and there is no IgM, this indicates past infection and obviously the patient has therefore recovered. If you have a patient who has both IgM and IgG positive but no RT-PCR, please keep looking for the RT-PCR and probably taking a better sample, because then the patient might actually be having a false negative test. So with that, I come to my take-home message. My take-home message today is stay home, stay calm. That is the most important point which one needs to take from my presentation today. What are the tests that need to be done? We need to follow the ICMR guidelines, and the currently tests which are available are the RT-PCR tests, and antibody tests are likely to come in soon. Please keep updated regarding the directives from the government, and the best that you can do is look at the ICMR website on a regular basis. They keep changing it usually in the evenings every day. And as Robert Plant in his song has said, even this shall pass away. With that, take care and be safe. Thank you for your kind attention, and should there be questions, I'll be happy to answer.
Thank you, Dr. Handoo, for the very informative sessions. Sir, we have many questions here. Okay. So the question is, this is on the blood transfusion. So is the blood transfusion in quarantine period good or bad?
So the point is, there are specific guidelines to this from what is called National Blood Transfusion Council of India, which in fact have already been in circulation. What is clearly mentioned is if there is somebody who is suspected of being COVID, even if he may be asymptomatic, the person needs to be deferred for at least 28 days. This is what has been given in that particular guideline. And probably that will be the best thing to do at this point of time. Though there is no evidence to suggest that this particular virus gets transmitted through transfusions. There is one or two publications which are available in the literature which talk about 15% cases having circulating RNA in the blood. However, that's not been replicated by others so far.
Sir, there's a question. Who recommends to prioritize testing for COVID-19? Do you think that all healthcare workers should be tested to reduce nosocomial infection?
Well, this is a very interesting question and at a tough time, because if you look at the current circumstances, we have limitations of kits. We have directives which have to be followed from the government and the Honorable Supreme Court. And at the same time, we also are expected to provide healthcare to the patients on the front. Now, there have been cases in the recent past where patients were not symptomatic and eventually they were found to be COVID positive, only ensuring that the healthcare workers who were providing healthcare at that particular point have all been quarantined. So if I am asked at a personal level, well, I would prefer all the healthcare workers to be tested. There is also an algorithm to this effect, which has come from the ICMR just of late. And perhaps it's just a matter of a time, maybe a day or two, when perhaps it will be allowed that all the people who are actually actively involved in healthcare, symptomatic or asymptomatic, might be allowed to be tested.
Okay. Sir, any chance of infection if we are dealing with blood or plasma of COVID-19 patient? This is from Dr. Varun Raj.
So as far as the blood and the blood products from a COVID positive patient are concerned, they have to be considered to be COVID positive unless proven otherwise. There is enough literature to suggest that there is no COVID transmission through blood, but we must remember that the blood is anyways taken in the tubes, and the tubes are being handled by human beings, and the human beings have a potential of transmitting infection through fomites. So please take adequate precaution. You do not need to get worried about handling these samples. These samples can be handled by usual precautions which you take in the laboratory. We are dealing with diseases like HCV and other diseases which are primarily transmitted through blood. When we can take care of them, I'm sure this is just a simpler way of looking at it.
So one last question, sir, which has been asked is that regarding this pooled testing for PCR, the pooled PCR testing. So what are your views on that?
So at a personal level, if you ask me, I am not really for pooled testing in this kind of a circumstance, because again, the pooling will depend upon how pooling is done. So if the pooling is done by taking the swab and then putting it in a single viral VTM, perhaps it may still work. But if you're going to take all the swabs in different VTMs and then you're going to take those VTMs and mix them up and then create it, the sensitivity, as far as what we have seen from the literature in the other cases, drops down significantly. But this is my personal view. Scientifically, there is evidence to suggest that this can be done potentially, and I'm sure the government will probably look into it and ask people to see whether this can be done or not done. Just look at the ICMR website, and next 2-3 days, hopefully something else will come up on this front as well.